Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters. I'm your host, Dr. Arti Thangudu, and today's episode takes us beyond exam rooms and lab values and straight into the power structures that shape how healthcare actually works in the United States. I'm joined by Chris Deacon, author of The Great American Healthcare Heist, a nationally recognized healthcare reformer who has spent decades inside public and private health systems, including leading one of the largest state health benefit programs in the country. Chris approaches healthcare not as an abstract policy debate, but as a problem of money, incentives, risk, and accountability. In this conversation, we unpacked why the U.S. can deliver extraordinary medical care, yet still financially devastate patients and burn out physicians, especially in chronic care specialties like endocrinology. We talk about who really profits, why meaningful reform feels impossible, and what patients and clinicians can actually do to reclaim control. This is an honest, uncomfortable, and necessary conversation. Let's get into it. Well, Chris, I'm so excited to have you here. I did read your book and I'm now obsessed with it, and probably you as well in the least weird way. But I loved your book. I thought you brought to light so many important topics in healthcare that are under-discussed and more under-discussed by physicians and patients who are obviously really important parts of the healthcare system. I feel like there's a silo of people who know about the topics you discussed with healthcare, and we're almost just preaching to the choir, while the people who are affected and may be able to affect change, if they spoke loud enough, are kind of just not made aware or are left in the dark about it. So first, Chris, I would love for you to sort of introduce yourself, tell us how you got to where you are, and then I have a few questions that we may follow or not. We'll just see how the conversation goes.
Thanks for having me. And again, I think it's such an important conversation to have with clinicians. I mean, so often we're just talking to the business folks on like insurance and administrative stuff. And it's like, to get to the heart of it, is patients and their providers, right? Like that's what this is about. So yeah, my name is Chris Deacon. I am a lawyer by training, but I haven't practiced for quite some time. I did practice for several years in corporate restructuring law, which has interestingly, I take a lot of that approach in my when I tackle some healthcare administrative problems in the healthcare space with employers. After I stopped private practice, I went into public service. I worked for the New Jersey Attorney General's office as a deputy attorney general. And then I worked in the governor's office in New Jersey, really getting to see how, the sausage is made, as they say. And then when that term completed, I went to the treasurer's office in New Jersey. And that's where I started running and overseeing the state health plan. So that's our public sector health plan in the state. Over 800,000 lives at the time, massive, billions and billions of dollars of taxpayer dollars and member dollars being spent. And that's where, I think I just got such a unique vantage point as to the functioning and dysfunctioning of healthcare, especially in the commercial space. I left in 2021 and started my own consulting firm. And I've just joined a new consulting firm or founded a firm called Judy Group, sort of the first of its kind firm that's what I'll call radically transparent and solely employer focused. But yeah, so that's where I am. I have 3 kids, a dog, and we're sort of football, soccer crazy at my house.
How old are your kiddos?
I have a 7-year-old, 10-year-old, and a 15-year-old, which I can't believe, but it's true.
I've got a 10-year-old and a 7-year-old too.
Okay. Yeah.
So I know the circus that we run.
Yes.
But so fun. So just curious, was there a moment for you? Like, was there a moment you're sitting in a boardroom talking to somebody that you were just like, what is happening here? Or like where it clicked for you that things weren't about the patients anymore?
Right. Yeah, I think I had several of those moments. I'll give you a couple of examples. When I first started with the state health plan, my first couple months, we had to run a PBM RFP, a TPA RFP, a consultant RFP. And sorry for the use of acronyms. Sometimes I feel like we live in them, but third-party administrator and pharmacy benefit manager. And in that process, we had our consultants come in who were going to help us run that process. And their sort of proposal was that we would be purchasing on the PBM side, heavily focused on rebates, on the size of the rebate guarantees. And on the TPA side, very focused on discounts and disruption. And given that I was fairly new to the space, I asked, I'm fine with discounts, but so long as we know the X, right? Discount off what? And I'm fine with a disruption analysis, but how are we accounting for positive disruption, right? If I'm cutting out the 10% of lowest performing providers in the state or lowest quality, I might be okay with that disruption. Where is that coming into the equation? Where's quality coming to the equation? And they did not have good answers for that. And same on the rebate side. And not only did they not have good answers, but they looked at me like I was crazy for asking such questions. And that I was, I've been told I was at the time, I didn't know what I was doing. I was too young. I didn't know how the industry worked. How dare I ask these questions? And so that was a real moment of like, this is going to be a lot harder to disrupt. And I didn't call it disruption at the time. I just called it smart. But, to do things differently than the way that they had always been done. I would say the second example of a big aha moment for me was, I'm sure you're familiar with the hospital price transparency rules that came about in 2021. And we had some exciting plans for this data with the health plan. We were going to ingest the files. We were going to use them to identify opportunities for perhaps a narrow network or identify, high value providers when bumped up against, sort of quality data. And when the hospitals didn't post on January 1st, we came up with a game plan to help, try and push them to become compliant. And so a letter was sent out from our TPA because we actually required them to have hospitals be compliant with federal rule and regulation. So I was going to use this hook. And within 5 minutes of that letter hitting the hospital CEO's desk, sort of pushing them on their lack of transparency files, I had a very angry call from the governor's office. How dare I piss off the hospitals, for lack of a better word? How dare I ask if they were compliant with this rule or reg? We have business with the hospitals. We have relationships that we have to keep. And so it's just an example of there are a lot of politics going on in the background when it comes to doing the right thing versus doing the thing that is politically expedient or politically, more promising for that particular administration or for that particular politician. And that was a hard learning curve for me, and one, quite frankly, that I'm never going to get used to or accept.
Yeah, I think that it's so complicated and non-transparent that we don't even know, like the average person doesn't even know the depths. And even me, like I think about this every day and I'm constantly reading about it and I'm still shocked all the time. Like, what? Like, that's why that decision was made? For the benefit of our listeners, Can we walk back and just give them a few definitions for some of those terms you use? Like, what is a PBM?
Mhm.
What's a rebate? What's a TPA? What discounts are we talking about? And also, like, can you tell our listeners a little bit more about that hospital transparency ruling and what the sort of intention was and what
Mhm.
actually happened with
Yeah.
it? Because I think all of those things are really interesting, and
Mhm.
most people don't know.
Yeah, sure. So I'll start with my acronyms. TPA is a third party administrator. So uh, essentially, they are supposed to, quote unquote, administer the claims for employers. So if I'm an employer and I have 5,000 employees or 800,000 employees, it doesn't make sense for me to go with a fully insured product. I'm going to self-insured, meaning I carry all the risk. I'm paying all the claims, and therefore I need somebody to actually do that for me. And I'm just going to pay them a flat fee. That is a traditional sort of third-party administrator. And all of the big carriers, United, Cigna, Aetna, Blue Cross Blue Shield organizations, they all act as third-party administrators and network providers for most self-insured employers, at least the ones that use those providers.
And there are a huge number of self-insured provider or self-insured employers, businesses. The majority of large businesses in the US are self-insured. So what this means essentially is there's a pool of money dedicated to healthcare in a company, and your company may be paying premiums towards that pool of money, but it's not actually going to Blue Cross, United, Cigna, Aetna. It's staying in the company, and then they use that pool of money to pay for your MRI or your doctor's appointment or your surgery, as opposed to just sending that claim on to an insurance company, which would be considered fully insured versus what
Right.
we're talking about is self-insured. And the reason that big companies usually prefer to do this is because they're in control of their monies, and it's thought to be more cost effective and beneficial to them to do it this way than to pay a premium to the other big insurers that maybe small companies do have to pay premiums to because they can't take on all the risk. They don't have as big of a risk pool or
Right.
the resources to create their own sort of insurance plan. So even if your card, for example, says United Healthcare or Blue Cross on it, it doesn't necessarily mean that that insurer is paying for anything for you. More than likely, they are not paying for anything for you. If you work for a large company, for example, your company is paying for it from this pool of money that they have allocated for healthcare. Now, why I think that is important is because so many people think that they are reliant on these big health insurance companies. Like, it is ingrained in the psyche of the American people that they have to have one of these big carriers because they are giving them this credit card that nobody else is paying. They're giving you this credit card that they're paying wherever you
The
show it
insurance
at.
company will pay for that.
The insurance company is
insurance
paying
company
for it.
pays for that. Yeah.
And that is a fallacy. That is a pipe dream. That is not true. You are paying for it. You are paying for it in some way, shape, or form through your taxes, through reduced wages, in some way. So I think it's really important for the American people to understand that their insurance company is not paying for things. Your premium is probably more than your monthly spend. You just don't know what it is because it's getting pulled from your paycheck.
Right. And I think that you're spot on that. And that's one of the reasons why I think, it's one of the reasons why I wrote this book is to try and through storytelling and in sort of an engaging way, educate, because I've heard, in the state of New Jersey, they've had Horizon Blue Cross Blue Shield for the last 35 years. So we have pensioners and people who think that insurance equals Blue Cross Blue Shield. Like, they're not even aware that other companies exist, much less the fact that they're not actually funding the claims, right? It's the state and it's the taxpayers and it's their counties and local governments. And yeah, I mean, how many times you hear somebody say, yeah, the bill is 100,000, but yeah, Blue Cross Blue Shield pays that. Aetna pays that. I don't pay that. And whether you're self-insured and your employer is paying it in the claims, directly, or even if you're fully insured, if you're a smaller business, or if you continue, your employer has chosen to be fully insured, you're still paying for that. It's just delayed a year, right? Because when that $100,000 claim hits, it's going to be taken into account next year when they tell you how much premiums you are going to have to pay. And that's where we get these 25% increases year over year. So yes, there is an element of sort of insulated risk in the immediate, but don't be fooled. You will pay for that. It might just be delayed a year in your premiums. So yeah, that's a great point to remember. And it's the same on the pharmacy benefit manager side. So you have a pharmacy card, or maybe you just have one insurance card, and your insurance carrier or your TPA is contracting with a PBM. But a PBM is like the quintessential middleman. They exist to negotiate the cost of drugs, right, for your plan. And they are not, typically in the traditional model, they were never actually touching the drugs. They are just negotiating with the manufacturers in order to get your health plan a better price, right? And one of the ways that they increased their profit margin and their take in the middle is by negotiating what we call rebates. So you might hear oftentimes that the price of a drug is, let's say, $50,000 a year for a particular drug, like a Stelara or Humira, right? The sticker price is $50,000, but the PBM has negotiated with that manufacturer to say, we will put your drug on our list of options called a formulary, our list of drugs that people will get access to. But in exchange for that placement on our list, you're going to have to give us a discount of, or I'm sorry, a rebate of, let's say, $40,000, right? So the price is 50, the rebate is 40, and that rebate isn't actually ever being passed on in the way of savings fully to the employer. Now, some employers think that they get a part of that rebate, and some probably do, but it's not often the case that is how the money flows. So that's why we have this huge debate in DC about pass-through and rebate models. I mean, because it really does beg the question, like, this is an insane game. Why wouldn't the manufacturer just charge $10,000, right? Instead of 50 with a 40% sort of cashback deal. Well, the reason that is, right, is also because when you go to the pharmacy to pick up that drug, what is the price that is based off of your copay? If you have a 20% coinsurance on specialty drugs, what is 20% of 50,000 and what is 20% of 10,000? Well, 20% of 50 is a lot more, right? And so you are going to be paying off of the sticker price. And there are so many things that are sort of based off that sticker price that sort of inflate the overall cost of things, even though there's money exchanging sort of hands in the back room between the PBMs and the manufacturers. And so all of these sort of upstream entities that have their hands in the supply chain. It is not as easy as, a drug manufacturing company selling to a pharmacist and the pharmacist sort of delivering that drug to the patient. Like, there are so many more players in that chain. And it's one of the reasons why pharmacy costs and spend are just astronomical, not only as a principal matter, but compared to the rest of the world. They don't play these games with pharmacy spend.
And if you're a listener and your head is spinning right now, it is not you. This is not a you problem. It is like stupidly confusing. And it's in a transparent world where we live in for other goods, it just wouldn't work. It doesn't make any sense. But basically there's there's three sort of levels that we're facing. Pharmaceutical manufacturers, so like the people who make insulin, the people who make Ozempic, to keep it in my world. Then there's this PBM, the middleman, and then there's the actual retail pharmacy where you go to give your insurance card and pick up your actual prescription. So pharmaceutical companies want to be on the formulary of your insurance company so that they can sell their product. And PBMs are controlling whether they are on that list of medications that you can choose from that are covered by your insurance. So if the pharmaceutical company makes a beautiful, wonderful drug, but the PBM won't get them onto your formulary, well, you're never going to get it because it's going to be not an option for you. The cash pricing is overblown. So like you aren't going to be able to, they're not going to be able to sell their product to you.
Well, and if I could just like point out, the economics of this and the incentives, because you're laying out the chain really well. So if you think about this, right? So if I'm a drug manufacturer and I'm like, you know what? I want to do the right thing. I want to bring down the cost of drugs. I want to produce, this particular generic medication that a lot of people need and a lot of people want. And I want to charge a fair price. Right? I'm going to bring my price down and I am going to undercut the market because not only do I want to do the right thing, I can still make a fair profit. So I'm going to go to market with this strategy. There is not a PBM in the world that is going to put that drug on their list, right? Their formulary, because the economics for the PBM don't work, right? If there's not enough room there to get their take, right? If there's a narrow margin on that drug because it's priced fairly, there's not enough room there for them to make a huge profit. And therefore, it's never going to make it into your hands as the consumer at a reduced price because of the economics of this system. I mean, think how bizarre. I mean, there have been studies that have shown when drug companies come to market and try to deliver a more fair and reasonable cost in line with other countries, they are getting denied access to the market through these formularies because there's not enough fat, there's not enough juice there for the middlemen. And that's that's the insanity of this chain.
And I think because we're talking about percentages, right? So if they get a 40% rebate on a $20 drug, that's just a very small amount compared to $1,000 drug, right?
Exactly.
And so that's why like we run into this a lot with GLP-1 receptor agonists. It's like, why is this Ozempic has been like $80 in France. I don't know how much it is now. It might be even less, but for years for a month's supply. Whereas here it was over $1,000 when it was still this really inexpensive relatively in other countries. And it's still, now that we have some price transparency and compounding that introduced like free market principles into the weight loss medication space, the price has come down tremendously, but it still hasn't met where it is in other countries. And I think you exactly hit the nail on the head with why, right? Because the PBMs still need them to be expensive enough that the patients will rather have their insurance pay for it than just pay out of pocket. But now because of the competition, they can't price them as high because people were just going to compounders and what we can say is if the medication price drops by 70% overnight, the pharmaceutical company is profiting off of the new price just fine. There was never a reason for it to be more expensive that relates to manufacturing or storage or anything like that. It was just falsely inflated for the profit of someone in this chain.
Yeah. And I think I watched a congressional hearing last year. I had the pleasure of actually being in the room and listening, and they were being questioned by, I think it was a Senate committee, and every single executive was asked about some of these more well-known medications that are quite expensive and said, how much do you sell it in France? How much do you sell it for in Japan? How much do you sell it for in Singapore? And it was all, 80, 90% less. And then the follow-up was, are you profitable in those markets? Yes. It was the answer every time. So you're right. It's not that the lie we've been told as Americans is if you want, innovation, and if you want new drugs, and if you want the best of the best in terms of the latest and greatest drugs, you have to pay this price because that's what you're paying for. And that's just not true.
Well, I think it becomes obvious when you look at the executive salaries, right? Like, I'm not saying that I think it's great for people to do great work and earn well because of doing that great work. But when we're talking about profiting off of my patients who are in need of care, like, these medications can tremendously change people's lives. And I'm not just talking about GLP-1s, but a lot of these medications that are thousands of dollars, hundreds of thousands of dollars that don't need to be. And people are dying because of it. Like, people die because they can't get their insulin. They die because they can't get their inhalers. It's not a small thing, we're putting profits over the sanctity of human life. And that is really hard, as a physician, to be in between that murky mess and to have had the veil kind of lifted to see how these systems work and the lies that we've been told too. It's really hard, but it's also like motivating and inspiring to see books like yours and people talking about this and trying to educate our own patients, because we do have that sort of lifeline, that connection with them to do it. But I think it's so important for us patients and physicians and business owners and like members of the community to be aware, because I think that's necessary for change, and change is necessary. I'm curious from your perspective, because you've been in this space from a different perspective than I had. How do you feel like healthcare financing, the way U.S. healthcare finance works, how do you feel like that affects the doctor-patient relationship? How do you feel like it erodes that doctor-patient relationship? And what does that mean?
Yeah, I mean, I think we'd all be, kidding ourselves if we said, no, it doesn't affect it, right? There's still a sanctity there. And there is some vestige of, let's say, sanctity in that relationship that is very quickly eroding. And why is that? That's, the corporatization of medicine, essentially. I mean, how many physicians are owned by United Health Group? Over 90,000. I think, again, like, that's a shocking number. It would shock 99% of Americans to know that the doctors that they go see, that, it is a very substantial chance that one of them is owned by an insurance company, right? Who they, might have certain feelings or thoughts about. And then there's increasing hospital system ownership of physicians and control. And so I think that while at the human level, there is and will remain a connection, between the patient and the doctor at the bedside, on the exam table, not just physician, but nurses and those like in the clinical space, that will continue to exist. But what I see as the biggest problem is the fear of entrance into that system. So fear of even walking into the door of that emergency room because of the cost and because of the cost barriers, or the inability to walk through that door because you are unable to give them your credit card information, or you don't have enough money in the bank to pay that fee up front for the surgery that they're demanding. And then, the cost of drugs, obviously that's a huge one too. And so I think there's a distrust of the system writ large, but there absolutely still exists something there in the relationship between, the patient and the provider community that is very strong. And I think that's a huge part of the reason why we've put up with so much from the administrative state, so to speak, because we do value that relationship so much. But it's certainly the more we are distancing patient from, provider, clinician, through these administrative layers. So, I'm going to throw some more acronyms at you, but it might surprise folks to know, but there's 27 touch points between a claim, like a patient encounter, and the physician actually like getting paid. 27 touch points on that claim. Like the further and further we get from the patient being connected to the provider in any real way, whether that's through increased inappropriate utilization management techniques or different policies or procedures, like I think the worse off we are. It's interesting to me that those employers specifically who have gone the route of direct contracting, meaning having direct relationships, like I'm paying the hospital directly. We're having a price for this thing, and I'm going to pay you directly. I'm cutting out the middlemen. And I'm going to hire a primary care physician for my workforce, and I'm going to pay them a salary, and I'm going to keep them on site, right? Employers that are doing this type of thing are called radical, disruptive, innovators. But let's think about that. They're just paying for healthcare, and they're getting their workers connected to a GP, right? A primary care physician to take care of them. Like we've gotten to a place where that's radical, right? Like that's disruptive. That's what medicine is, right? Like that's what the first employer health plan was in the early 1900s, when employers found out that like, I can improve absenteeism, I can take care of my people, I can attract my people, I can take care of my people if I help them with their healthcare. So I always think it's interesting to sort of step back and like from a like macro view and think how crazy it is that facilitating that direct relationship is innovative and disruptive.
Yeah, it's like direct care is so funny in that way because it's like the original way doctors practice. Like you had your clinic and people came to you and they paid you dollars or in eggs or whatever they happen to have. And like, that's how it worked. That's how every other transaction, that's how we buy our groceries. That's how we buy everything, right? Like a transaction between the provider of the service or the product and the consumer who is also the customer. Now we have this really bizarre system where the payer is the insurance company. The patient thinks that they're the customer, like they should be the one receiving good service, but they don't think that they have to be the payer. And then the doctor is controlled by the insurance company or the hospital system because the doctor is paid by that system. And it's a huge ethical conundrum. And I'm not saying that every employed physician is making decisions on the behalf of their insurance company at odds with what is best for their patient. That is not true. Mm-mm. That's not what's happening. However, every doctor is being faced with a bunch of barriers to provide their patient with the care that they believe they need because of the system, the healthcare systems, hospital systems who are dictating the physician's schedule. If a doctor thinks their patient needs 30 minutes, but their clinic only has 10 or 15 minute blocks, well, guess how much time their patient gets? Right. Their patient gets 10 or 15 minutes, or probably 5 minutes, because that 15-minute block is for them to get vitalized, their medications reconciled, the doctor to see them, the doctor to write their note and write their scripts. So they get 5 minutes, right? And so there's this ethical dilemma that a lot of doctors are facing. And Wendy Dean talks about it a lot. I don't know if you've heard of her, but she talks a lot about moral injury. When you know what is right and you're put in a system that doesn't allow you to do that. And what we as direct care physicians are trying to do is say, hey, I want to answer to my patient. I don't want to answer to an insurance company. I don't want to answer to a hospital administrator who's never seen a patient in their life. I want to answer to my patient, and I want to succeed because I do right by my patients, and that's it. And I'm a very simple person. Like when I graduated from my fellowship, I was working in a big insurance-based private practice, and when I started learning more about like the non-transparency, like what was going on kind of behind the scenes, the motivations for my partners who were 10 years down the road compared to my own, I was just like, this sounds stupid. This sounds like a system that's going to fail me, my family, and my patients. I'm just not going to do it and figure out a way where I can actually serve my patients to the extent of my knowledge. Like, it was really that simple. But I think when we're coming out of training, we have overwhelming debt, or, you've been in practice for a few years and you are accustomed to a certain lifestyle, it's really scary to like jump off the deep end, and also patients have, it's changing a bit now. And maybe it's just because I have like sort of built my reputation from when I started with none. But patients are very weary of direct care. They, patients are so accustomed to doctors accepting their insurance, and people don't choose their doctors based on who's the best doctor for me anymore. They choose their doctors based on who's in my insurance network,
Yeah.
And so patients are very weary of direct care because they are just, it's unusual to them to have to pay a clear, transparent price, which is fascinating, right? Because like, in what other world would you like go to the grocery store and say, okay, I want to buy peaches, apples, Lunchables, whatever it happens to be, and you'll just bill me later. Don't put any prices on. Just send me a bill later, and I'll pay whatever that is at that point. Like, that's insane. Nobody would ever do that because, of course, you're going to get price gouged, right? They're going to take advantage of that. But that's exactly how we shop for healthcare.
Well, and I think, it's not just the sort of lack of familiarity with direct pay. I think that there is an intentional, I don't want to say, an intentional education to make people think that they have to have health insurance as like, that's like, they have to use their health insurance. And I think we witnessed this in the last, government shutdown debate over the ACA subsidies. We conflate healthcare with health coverage, right? We have to have health coverage. Because we have to have our insurance card, because that's the only way you're getting access to care. And I think most of us know that that is absolutely not a guaranteed, golden ticket to care. It is definitely not a golden ticket to care in behavioral health in any way, shape, or form. And not in other ways either. And there's a barrier to entry there with out of pockets and, deductibles and that are all going up as well. So I think it's not just a lack of familiarity. There's like an intentional misinformation or disinformation campaign to keep the legacy system in place. Because again, with your practice, right? If individuals learned that they could go to you, get seen sooner, get more time with you, and pay a fifth of the cost or whatever the price is, well, that value proposition for that network thing, like, where's the value? There is none, right? Yeah. And so that is a very, very uncomfortable reality for a huge part of that $4.9 trillion pie, or what is it, $5.6 trillion pie now, that is the healthcare spend in America. So, I hate to be a cynic, but I do think that there will be barriers put up for direct pay, the direct pay model that is the natural outgrowth of transparency. It has to be.
Well, I think you're absolutely right, because there's this almost, I want to say, brainwashing, like there's this, my husband and I were just talking about this yesterday in the hospital. He was getting really frustrated because some of the staff was essentially like frustrated with the patient for not having insurance. And not having insurance is almost seen as a moral failure. And not having insurance when insurance premiums are more than $2,000 a month isn't a moral failure. It's a systematic failure. It's too expensive, you know? And some people cannot afford it. Many people can't afford it. And I think that's like not just ingrained in the psyche of people, like patients, the community, that we need to have health insurance. It's ingrained even in, sadly, healthcare providers, you know, like patients, somebody made a mistake because they don't have health insurance, and now they're in this situation where they're sick and they need care, and it's their fault that they weren't covered. But really, when we take a step back, if they could have, they probably would have, you know. So I think that's something that we really need to push back on too, and talk about the truth of the matter. You know, I think being uninsured, like, there's so many levels. Like, you could be insured, and like you said, health insurance is not health care. So you could still pay a lot of money even though you are also paying a premium for health insurance. And those premiums are so high that people might make a financial decision to not have health insurance, thinking that, you know, hoping and praying that they don't get really sick, right?
Right.
But it is really hard. One thing I heard you say, I can't remember if it was in like a LinkedIn post or in your book or somewhere, is you mentioned that if you had an ill loved one, there's no healthcare system that you would rather them be seen in than the U.S. healthcare system. And I think that's because of the quality of care, the quality of care that they would receive here versus maybe some other places in the world, obviously depending on what the condition is. But at the same time, how do we reconcile that with the financial toxicity with the care that comes here? Like we can't just say the U.S. healthcare system is bad, right? Because there are several pieces of the puzzle that some are good, some are bad.
Yeah. So so that story was in the book. It's sort of in the closing of the book, and I had just a quick recap of the story. And unfortunately, I was present when a young man was crossing the street at my kid's school, and he was hit by a car going 40 miles an hour, and it was devastating and tragic. And I was there with him right after he was hit, and, you know, was there when the EMTs eventually came. And I remember very, very distinctly, like, having this, because I was in the UK, and when this happened, and it took the EMTs about 20 minutes to get there. You know, I don't know if that would have been different in the US. He was then life flighted to, you know, one of the best children's hospitals here in the UK, which I'm sure is amazing. However, right, like, I do believe in the innovation and the quality and the amazing professionals that we have in the US, because it is a remarkable place to practice medicine. I believe that. And you know, I don't know if that's just, if, you know, my gut is right or not, but it was so powerful that it made me remember and recognize that there is something here worth saving. And so while the financial mechanics around the US healthcare system are very broken, and or not broken, but working towards the wrong aim, we still have something to save. And I do think that this is where, again, moving that relationship between sort of the immediate individuals that need to be a party to that healthcare transaction, meaning patient, like the person that's paying for the patient, whether that's an employer or the patient themselves, and the provider. The closer we get to connecting those two or reconnecting those two directly, the better. We need to have, and I often take hospital systems to task for some of their bad behavior and profiteering and whatnot. At the end of the day, we need hospital systems. We need hospitals. We need viable, financially successful hospitals so that they can innovate and invest in the next generation of physicians. And we need that, right? And what we don't need is the 54 layers in the middle between that hospital and the patient and the party that's ultimately paying for that care. And that's the opportunity. That's the 30% of spend that we could then, put back into the pockets of patients and workers and taxpayers. And that's 30% we could reinvest and make sure that we are at the top of our innovation game. But, again, I think that we have a lot of really great parts of our healthcare system, but we will lose it, and we will continue to lose that trust. And we will lose in, lose or win. I don't know what the right one is in DC, in terms of what the takeover looks like. Like, we will eventually get to a point where every public sector entity has gone bankrupt because of the cost of healthcare for their employees. Like, New Jersey's insolvent, their healthcare plan now. Texas, Montana, a number of school districts that I've seen, like, where they're not hiring teachers because they can't pay for healthcare. Like, we have reached a breaking point. We're just seeing how far we can bend. To your point, like, physicians, I honestly believe that the clinicians, they want to do the right thing. But when, for example, they are, in the hospital and they need to, order a med, and they go onto their tablet to order that med, and that the first thing that populates is not the medication that might be most efficacious for this condition, but is the drug that they can buy off of 340B at a steep discount and make the most profit from, which happens. That is systematized, right? Like, that physician is just doing their job. They don't know that. And there's all sorts of things like this where it's become part of the system and not necessarily an individual making a choice to do something that's not in the patient's best interest.
Yeah. And I think, it's hard to be a physician and you have these like like exactly what you said. It's hard to like take a giant step back and think about it. I think a lot of physicians are just, they're trying to get their work done. They're really, really busy. And I think that the system has taken advantage of that fact that they don't have time to advocate for anybody, for themselves or their patients. And they've just kept them busy working, seeing more and more and more patients. But if you happen to be a physician listening to this, like, it is also our responsibility to protect our patients, and protect our profession. And we have to figure out a way to look at the big picture, like get out of the microscopic day-to-day tasks and do something and say something, because like we just owe it to everybody who matters, right?
To your point at the beginning, it is uncomfortable. And I understand why a physician that might have gotten into this business to do the right thing and is just trying to keep their head above water, whether that be financially or from a time perspective, like they don't want to have to think about those things. Now I have to fix the healthcare system. I just want to practice, right? But to your point about the profession and the trust, like, it is uncomfortable, but it needs to happen. And the first step is education. Right? Mm-hmm. I mean, just like what you're trying to do here with this podcast, education is step number one. And I guarantee you can't not look after you become aware of some of these things.
Yeah. Yeah. And, acquiescence is a choice too. You either make a choice that is helpful or hurtful. And there's really no in between when it comes to healthcare and our patients. Right. And so, it is tough. And I know that it's not for everybody. I never thought I was going to do this. Like, I thought I was going to be an employed physician in a clinic. But once I started seeing things, like, I couldn't stomach it anymore. And so I think exactly education, starting to become knowledgeable is more important than ever, especially if you're a young physician. You have the next 30, 40 years of like working in healthcare. So it's either going to get better or it's going to get worse, you know?
Right.
And you may as well be part of trying to make it better. So before I let you go, if you were to say 3 things that people in our community can do to perhaps move healthcare in a better direction, what would that be?
So somewhat self-promoting, but it doesn't have to be my book. But I would say education. I think if you, I'll just use my book as an example. If you bring yourself up to speed on some of the things that are going on, you cannot walk through life in the same way. When you go to a sporting event and you see your nonprofit hospital system plastered over every luxury box and jersey, you might then ask a question like, I wonder why, right? Like that's happening. Or when you're watching a commercial and you suddenly see, Venus Williams promoting a new drug, right? Like, why are they pushing this drug? Who paid for that drug or who paid for that advertisement? If it's, and I think that, so I think education is key. And once you sort of open that lens, like you can't unsee what you've seen, what you've learned. Another thing I would say is very practical, but when you get those explanations of benefits or those claims, or, we have a tendency, because there is no trust and we think it's all funny numbers, and which is kind of crazy that we're like, yeah, those numbers don't matter because they're not real, right? Pay attention to them, right? Pay attention to what your employer is getting billed for, what you're getting billed for, what your provider is getting paid, right? Did the provider bill $15,000 and the insurance company is willing to write them a check for $1,500? Like, why is that? What's going on there? Because this is also your provider who is, if the service was actually worth more than $1,500, they're getting shortchanged, right? There was an example, just real quick, of a case in California where an employer paid $4 million for a claim. It was a psych claim, a very high cost claimant, $4 million. What the employer and probably the family and the patient didn't know about that $4 million claim was that the provider got $800,000 of the $4 million, right? The rest of it went to the insurance company, who kept it as a savings fee, and their third-party savings vendor, because they said they negotiated that bill down, right? Like that is obscene. That and it happens at both large scales and smaller scales. But pay attention to those documents and then ask questions.
So let's break that down for a second, because I think we need to slow that down. Okay, $4 million were paid by an employer, and the insurance company who's like helping with
their
the
third party
network,
administrator. Yeah, their TPA.
Okay, so yeah, they're administering the plan. They're not actually paying anything to the provider. So the provider is like all of the doctors that you're seeing, the nurses, the techs in the hospital, the respiratory therapists, the hospital fees, the hospital bed, the janitors, like all of that. It's not just one doctor, right, that's getting $800,000. It's all of the team that's actually doing the care. They got paid less than a quarter of this massive amount of money that was paid for this illness that this person had. And the rest of it was paid to essentially a middle person who did nothing really, and so what a waste, waste of money. How, $3.25 million or $3.2 million can do so much good in the world. It can help so many people. It can provide so many medications. And this is just administrative bloat.
Right.
Even if they took $200,000, they would still make that's a lot of money for doing nothing.
That's a great return on your time. But yes.
And so I think, okay, I just wanted to make sure people understand the weight of of what that means.
Right. Yeah. I mean, another example of a colleague that I have, his wife had a surgery, a back surgery. They knew the physician. He was out of network very well. They thought highly of him. They did their research. This was the surgeon they wanted. The bill was around $40,000, and she paid for out of network coverage. So, this presumably should have been covered, right? Generously, according to the terms of the plan. That provider was offered like literally pennies on the dollar for the surgery and said, take it or leave it. That's what you're getting. And you can go after the member for the rest of it. And then kept the difference, right? So $40,000 was, paid by the plan, right? But pennies on the dollar were paid for the actual claim. And what happens to the middle? It disappears. And in there, in terms of, as you said, this is what's driving the 10% year over year increase in healthcare costs. I don't know many doctors who are saying I got a 20% raise every year for the last 10 years. Like,
yeah, it's
by and large,
opposite.
staying pretty flat, right? Employers are paying more, taxpayers are paying more, physicians are staying maybe a slight increase, not a lot. What's happening to this money? Right? Just look at the shareholder returns on United Health Group. That's where it's going.
And this also leads to this distrust issue that we discussed before, because if you, patient, are paying $40,000, patients associate the care with the care that they received, the face that they saw. Right. And so they think that their doctor is getting paid $40,000 for the surgery they performed when they're probably getting paid $1,500 or $1,000 for being in the OR with you for 10 hours, and so I think what you said exactly about the EOBs and really kind of tearing apart, like, what are these dollars actually going to, is really, really important, because we're in a place of massive distrust of, and, I take care of patients. So I know that not every single patient doesn't love or believe their doctor when they talk to them. It's overblown on social media for sure. I have wonderful, wonderful patients and wonderful relationships with them. And I know that they believe me when I speak to them and all of those things. So I do think it is possible to still have good relationships with our patients, but on social media particularly, there is massive distrust in physicians. We're bought by pharma. We are gatekeeping therapeutic options, like all of this stuff that is probably for someone else's financial gain, whether it's an influencer selling the newest lotion or potion or whatnot. But the distrust begins kind of under in a way that we don't know. It's imperceptible. It's this healthcare system. Yeah. It's the 5 minutes appointments. It's the surprise bills. It's the lack of access. All of these things have kind of set us up for distrust in the more traditional allopathic doctors, and let kind of charlatans take over. I really think it has very little to do with the medical judgment. Right. It has to do more with the system.
Well, so I call it the congressman problem. And what I mean there is that everybody distrusts and thinks Congress is broken and doing a horrible job, but not their congressman, right? So very similarly, everybody knows healthcare is broken. The system's broken. They don't trust anything. They don't trust anything about it. But my doctor's good. And what that is, yes, it's sad, but it's also an opportunity, because that trust, if not wasted and lost, can be leveraged, right, to rebuild something better. Right. Mm-hmm. So, it's got its upside and its downside, but we definitely do have that problem, but we also have but I trust my congressman and I trust my doctor.
And, when they survey people do still have a high level of trust in their doctors and a low level of trust in insurance companies. So I think that we do need to like capitalize that. We need to invest in our
Mhm.
patients, right? Invest in that relationship. It's a very important relationship for their healing and also for our to make medicine a palatable career. The
Mhm.
relationships are everything. So I think I cut you off after two. Did you have one more thing that you wanted to add
Um,
about potential solutions?
yeah, I mean, I think I kind of outlined what I see as sort of a guiding principle in moving forward as an industry, and that is more direct relationships, and whether that's more direct financial relationships or actual relationships um, in the system, and shrinking down the layers of middlemen as much as possible. And we see this, for example, again, I talked about like a healthcare claim, right? It is insane and absurd that in today's day and age with technology, the technology we have and the payment rails we have and the data capabilities we have, that we aren't able to effectuate a transaction where, a file, or a data is immediately moving between all of the vendors on this or all of the folks on this chain, between an employer, an employee, a third party administrator who adjudicates the claim, and the provider, that isn't moving at the speed of light. Payment is being made quickly. Adjudications are happening. Like, we're quality checking the data quickly. Like, these things are taking weeks sometimes. And it's not because we don't have the capability. It's because we, some industries and some companies profit from that time span and from that lack of transparency, and keeping, where there's mystery, there's margin. So, I would say to anybody in the technology field or like, we have to embrace technology in a way that restores sort of what we were talking about earlier, sort of the fundamentals of healthcare and practicing medicine.
Yeah, the lack of it, somebody's profiting off of the lack of efficiency. And
Absolutely.
yeah, I thought that was really well outlined in your book. Is there anything else you'd like to add before I let you go? I feel like we could talk about this was like a surface level conversation, and every little topic could be like a full podcast in itself. So we'll have to chat more offline. But anything else that you'd like to add before I let you go?
No, I mean, I think we covered a lot. And I think if I went down another rabbit hole, I'd go for another hour. But just, I appreciate you having me on and giving, me and folks like me the ability to help educate and to try and, spread the word, because I do believe, and I did say this in the book, that the one last great untapped resource in this fight, and it is a fight, it is a battle, is the sort of the might of the American people, right? The American people know that something's broken. They're angry about it and they're upset about it. What they don't know is exactly what's broken and how to hold politicians and leaders accountable to fix it. And so, again, going back, sort of like circular, the education piece, the continuous education piece, and that will have the power or the ability to harness that power and hopefully bring change.
Yes, yes, I agree 100%. And Chris, where can people find you?
I am on LinkedIn. And folks can feel free to email me at chris@judygroup.com, or you can just email me or message me on LinkedIn as well. I provide a lot of content on there.
She does. Definitely follow her on LinkedIn, chat with her. And you guys, you have to read her book, The Great American Healthcare Heist. It is so good, and it isn't, it's really easy to read, really digestible. You don't have to know a whole lot about healthcare, certainly not about medicine, to really learn a lot from this book. So, pick up the book. It's available everywhere. I got it on Amazon, but you can get it anywhere. And just really, really well written. And I'm just so proud of women doing amazing things in the world, and so young and getting stuff done. But thank you guys so much for listening. Your support means the world to us. Please subscribe to this podcast if you like this episode, and you can find me on Instagram at Dr. Arti Thangudu. Have a great day.